So today's topic is MASLD pharmacotherapy. My name is Emily Przybyl. I'm a PA at the Erie County Medical Center in Buffalo, New York. This is our QR code to record attendance for this meeting. And this is regarding some more information from the GHAPP, MASLD and MASH community network. And Madrigal has some more educational material. So let's get into it. So we're talking about currently available treatments for metabolic dysfunction management. So first off, we want to incorporate all aspects of what we have on the screen here. We want to encourage weight loss through diet and exercise. We can look into if they're eligible for weight loss medications, including the GLP-1s. We can also offer a referral for bariatric surgery if that's something that patients are interested in. Every patient is a little bit different. We have to kind of fine-tune their treatment plan depending on their circumstances. And for everyone, we're wanting to reduce their cardiovascular risk, managing their comorbidities, whether or not they have diabetes, high blood pressure, high cholesterol. We want to manage all of those. And then in addition, we want to, determine, are they eligible for liver-directed treatment? Our top treatments that we'll be discussing today include vitamin E, pioglitazone or Actos, and resmetirom or resmetirom. So first we have our GLP-1 receptor agonist. So after food ingestion, your endogenous GLP-1, so you have GLP-1 in your body, stimulating glucose-dependent insulin secretion. It suppresses glucagon, delays gastric emptying, directly acts on the hypothalamus to promote satiety and reduce energy intake. So the GLP-1 receptor agonists are going to mimic that gut-derived incretin hormone, which will lower your blood glucose and result in weight loss. So the role of the GLP-1 in hepatology, the semaglutide in 2.4 milligrams weekly is a pretty big dose, but that's what the study was based on. They successfully met both primary histologic endpoints at 72 weeks, showing significant MASH resolution without worsening fibrosis and significant improvement in liver fibrosis without worsening MASH. So essentially, we want to either halt that progression of fibrosis and you can kind of resolve that steatohepatitis, stop that inflammation, stop that burning within the liver. Some patients respond really well, and they can even get a reduction or improvement in that fibrosis number, which is really exciting. And consider administering GLP-1 for overweight MASLD patients with a higher propriety given those with MASH. So obviously not going to be eligible for your lean MASH patients. Won't really be helpful in that scenario. Some things that we do need to worry about from a GI standpoint, that those medications cause delayed gastric emptying. So if you're planning on referring your patients for, a screening colonoscopy or an EGD, they absolutely have to hold the medication for at least 7 days, or they're at high risk for aspiration. Next up, we have vitamin E. The typical dosage is 800 units per day. Indication in non-diabetic MASH patients without cirrhosis. So the PIVENS trial looked at a study indicating that vitamin E improved liver histology in non-diabetic adults. The effectiveness was approximately 43%, showing improvement in in the histological endpoints there. Limitations, not all patients respond, and not every patient can take it. We're limited. You cannot use it in patients that have hypertension or diabetes. And then we do have a mixed bag here in terms of recommendations. The AASLD guidelines suggest that it may improve NASH, while the 2024 EASL or the European guidelines do not recommend it as a MASH therapy due to limited efficacy. And there are potential risks with it. There's a bleeding risk, increasing risk of prostate cancer. So patients think that, I can buy it over the counter, it's safe, but it's not necessarily the case. So you definitely have to have a risk-benefit conversation with your patient if you're considering starting this. Our pioglitazone or Actos, typical dosage being the 30 to 45 milligrams per day, indicated with MASH patients with or without type 2 diabetes. Again, our PIVENS trial showed that there was really no benefit over placebo for the primary outcome improvement in histological features of MASH. However, significantly improvement for secondary outcomes with improvement in cardiovascular risk. So not directly improving that disease process, but getting some secondary benefit, improving their overall cardiovascular risk. And again, there are some safety considerations here. It could cause weight gain, edema, bone fractures, increased risk of bladder cancer. So again, definitely need to have a risk-benefit conversation with your patient. And then we are moving on to resmetirom. So it became FDA approved in March 2024 in conjunction with diet and exercise. So definitely not replacing your diet, exercise, and lifestyle changes. It's definitely in conjunction. So it's treating your non-cirrhotic MASH patients and currently only approved for patients with liver fibrosis F2 and F3. It is a thyroid hormone receptor beta agonist, and it selectively binds to and activates the thyroid hormone receptor in the liver. So this slide is basically just saying that the thyroid is directly responsible for the metabolism within the liver. In the middle of the slide there, we have our thyroid receptor beta agonist, essentially just directly responsible for the fatty acid oxidation. And this is our Maestro-NASH trial. It's still ongoing. The trial studied adults with biopsy-confirmed MASH in fibrosis stage F1B, F2, and F3. They were randomly assigned to resmetirom 80 milligrams, 100 milligrams, or placebo. The two primary endpoints at 52 weeks showed NASH resolution, and including a reduction in the NAFLD activity score, the NAS score, which you can only determine that from a biopsy. But they reduced it by equal or greater than 2 points with no worsening of fibrosis, and also an improvement or reduction in fibrosis by at least one stage with no worsening of the NAFLD activity score, which is really exciting, which on the last meeting we talked about the progression of fibrosis, which is typically, the average being one stage over 7 years. So they went from stage 1 to 2, and that took 7 years to get there. But with 52 weeks or 1 year of resmetirom, some of these patients were fully reducing that by a full stage, just to put that into a little bit of perspective there. The side effects. Most common side effects associated with resmetirom being diarrhea and nausea. from my patients, itching is also a common adverse side effect. Typically, it's worse at the beginning, gets better over the first few months. And the diarrhea seemed to be more prominent in the higher dose, the 100 milligram dose, rather than the 80 milligram dose. But really low incidence of serious adverse side effects. Our phase 3 primary endpoints. They were superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least one stage. So honestly, pretty similar to between the 80 milligram and the 100 milligram dose. And the resmetirom is a weight-based medication. So I believe if they're over 100 kilos, they get the 100 milligram dose. If they're less than 100 kilos, they get the 100 or the 80 milligram dose. Practical considerations for managing MASH with resmetirom. So the ideal patient, it's currently not FDA approved for cirrhotic patients. So we're really trying to weed out the patients with moderate to advanced fibrosis, including the F2 to F3. And again, we're still trying to encourage patients to use this in addition to diet and exercise. This isn't a cure-all. It's another piece to the puzzle to treat the disease process. And some other considerations, there are some drug-to-drug interactions. On the left there, you need to avoid it with that list on the left, which really aren't very popular medications, but obviously something that you should be aware of, that it's a no-go. You should definitely not be using them together. In the middle there are some medications that we need to dose reduce. For example, if they're on Plavix and based on their weight, they would be the 80 milligram dose. We would reduce that to the resmetirom 60 milligram dose. And if they're on the 100, we would reduce it to the 80 milligram dose. And then on the right there are some medications that increase the risk of exposure to resmetirom, meaning for these medications, we would reduce that dose. Like for the Actos, the maximum dose would be the 15 milligrams per day. And then we also want to be mindful of their statin dose. I always confirm that dose before I send that medication. You only take atorvastatin 40 milligrams, correct? Just want to really confirm that before you're prescribing that medication. And if they are on a high dose statin, getting the PCP or the cardiologist involved to make sure that we can safely, reduce that resmetirom or the statin dose to allow the patient to safely take resmetirom in addition to that. So considerations managing MASH patients with resmetirom. So there's a lot of inconsistencies on how often we should be monitoring the patients with, blood work, imaging. We're still kind of figuring that out as we go. My personal opinion is that, I would keep the patient on for 52 weeks, keep them on for a full year, and then reevaluate with your non-invasive testing. So non-invasive testing being your elastography or your fibroscan. The PDFF is a fat fraction that you would obtain from an MRI. Currently, we don't have that in the Buffalo area, but again, that's an option if it's available to you. Or the ELF test, which is a serum test. So again, my personal opinion is waiting that full year, keep them on it if they're tolerating it, and then reevaluate with the NITs to determine is it beneficial and whether or not we should continue the medication long term. Some other questions that remain, some widespread resmetirom use will depend on insurance coverage. Luckily, I have a really great nurse that handles all of my prior authorizations. At the beginning, I will admit that it was a bit of a a hassle trying to get this approved. Patients were waiting months to get drug in hand. That has significantly improved. Some patients are shocked. They're like, oh, I got it in 2 weeks. And, that's great. That's what our goal is. But just trying to be upfront with patients that the process can take quite a bit, and to be patient. We're still kind of, again, working out how often should we be testing their LFTs. Typically about 4 weeks after starting the resmetirom, you will see a bump or an increase in their AST and ALT. That's expected. But again, should we be checking that to make sure it's not too high, or do we just say, no, let's just check it at 3 months and not worry about those possible elevations in the AST and the ALT? Again, how long will patients be on this medication? Sometimes we're a little bit unclear on that right now. Again, I say at least 52 weeks, just to kind of give the patients some perspective on, am I going to be on this medication forever, or is this a short-term solution? And then there are some other medications on the horizon, so we will be having some more options in the future. And you can have patients on multiple. You can also push for patients to get started on that GLP-1 and the resmetirom. You're not kind of tied into one treatment option here.